A leading expert on pharmaceutical economics and public policy, Dr. Schondelmeyer has spent his 40-year career working extensively on competition and pricing of drug products, affordability and access to drug therapy and pharmacist services, coverage and reimbursement policy under public and private third-party programs, and policy and trends within the pharmacy workforce. He serves as the director of the Prime Institute, an independent global research, education, and consulting organization whose mission is to study economic and policy issues in order to improve access to pharmaceuticals and pharmacist services. He is the Century Mortar Club Endowed Chair in Pharmaceutical Management and Economics and head of the Department of Pharmaceutical Care and Health Systems within the College of Pharmacy. Please join me in welcoming Dr. Schondelmeyer.
Well, first, I'm glad to join you. Second, I want to burst the bubble and say I probably won't answer all the questions you have about economics and pharmacogenomics today, but I hope to raise a lot of important questions about economics and pharmacogenomics. So I'm going to talk about pharmacogenomics, why bother, who pays, how much. And I always like to give an overview of what's going to be covered. First, I'll talk a little bit about the legacy of genetic testing. Then why bother, who pays, when will they pay, and then kind of what's next in terms of payment and coverage of pharmacogenomics. What are the issues in terms of implementation and efficiency that need to be addressed for this to really take off? So first, the legacy. I don't need to remind you, you know this, but I remind you because you talk to yourselves within this discipline a lot. But we have to remember that patients in the social world and legislators and insurers and payers and the rest of the world has a memory about genetics that comes from the old days. That memory really is a legacy of a historical negative view. Genetics was a way that we found out bad things that could happen to us. Genetics, it was good, but it was bad things we found out. We used it to find if one has a disease-causing gene or if you're going to have a hereditarily inherited disease that's going to develop later in life. And so genetics has this negative baggage to it. I think we're well on our way, and after hearing today's presentations, we're greatly overcoming that, but we have to get the rest of the world to overcome that view also. And then genetics was used to penalize us in our life. It was used to penalize us in our health care pre-ACA. Now that supposedly is illegal, inappropriate, but you might know that some of the firms who recruit members into their insurance plans use various techniques to recruit patients with certain characteristics, which results in, you could argue they were or weren't trying to eliminate certain people. Also, it could affect how one gets a job. Now again, it's supposedly illegal today, but there are remnants of that still around. And finally, it still may affect the cost of your life insurance if we know certain things about your genetic past. I'm not saying this to bring us down, I'm saying this just to remind us, A, where we've come from, and then B, what still kind of is around us in the milieu of how genetics are viewed in the world. So why bother? Now I want to give you the positive side of things that I've heard you say as I reviewed the literature I find. Pharmacogenomics can improve or influence drug therapy. It can improve drug response. It can improve outcomes of care. It can avoid adverse effects. It has to be integrated into practice. It still has to be integrated into our information systems, has to be integrated into our payment systems, which I will talk a little bit more about in a minute. And then pharmacogenomics needs value propositions for each and every test and drug in use. We can come up with some general models for value propositions in pharmacogenomics, but we need to apply it to each drug and each use and each test and make sure that that value proposition is met. And remember, part of that value proposition is not just the clinical evidence of what works, but what does it cost us in the system and what costs can be avoided by that, and can we actually realize those costs? So who pays for pharmacogenomics? On the one hand, employers. Here at the University of Minnesota, we're a self-insured employer. I help to manage our health benefit and drug benefit programs, and we do pay for pharmacogenomics tests. Now, we don't have an explicit list that says, here are the 47 things we cover and here are the 23 we don't, but we pay for them. They do go through, they are paid for. Most physicians who see our patients don't know that we pay for them. Most pharmacists who see our patients don't know that we pay for them. Most patients don't know, but we do cover them. We're like many employers in the world today. It's out there, we're paying for some, we're not advertising it, we're not pushing it, but it happens and you can get through the system if you take the effort. But a lot of providers, patients, give up in the process and don't pursue payment. Secondly, insurers, large insurers, managed care systems do pay for pharmacogenomics in many cases. With a graduate student and Dr. Jacobson and others, we looked around at the websites of the major health providers in the Twin Cities, and maybe 2/3 of them had something on their website about pharmacogenomics, but it wasn't very detailed, and you couldn't tell exactly what was or wasn't covered from that information. When we contact them, a couple of them say, oh, we have much more detailed policies, but we don't publish them. I did find some national insurance companies that publish extensive documentation of what do they cover, how do they cover it, and what's the justification. 2 or 3 sites, and I'll give a couple of examples from those, have documents that are 150, 200 pages with detailed information about each test and what their analysis of the clinical and evidence studies are with respect to coverage. Then there's government. Our pharmacogenomics covered by Medicare, by Medicaid, by the VA system, by Indian Health Service, by other health systems. And yes, they are covered under many of those, but again, the rules vary. Often they're not very explicit, and if you know how to get through the system, you can get it covered, but if you don't, good luck. And then ultimately, consumers can and occasionally do pay for these out of their own pocket and pay for them themselves. So how does this pay work? Employers, if they have to pay a lot more for pharmacogenomics, this will affect, they will either hold down or not increase the wages of their employees or lower them. So yes, they do pay for them, but there's a trade-off. Insurers, if they are going to cover pharmacogenomics, just like if they cover new drugs or new medical procedures, this will raise the premiums. If government covers new procedures, pharmacogenomics, new drugs, new medical procedures, then that results in higher taxes for us to pay for the Medicare and Medicaid programs. And finally, consumers are paying cash out of pocket. And I make the point here about who really pays. Who really pays? Insurers don't really pay for anything in healthcare, they just process the payments. Ultimately, at the end of the day, the consumer is the one who pays for everything. And that's true whether you're taking lower wages, paying higher premiums, higher taxes, or cash out of pocket. And I don't say this to say it's bad or that it's impossible to raise the funds, but we have to realize the money does come from the individual eventually. We have lots of systems in the way. We have lots of processes and insurers and government programs and employers who kind of mediate and help make some paternalistic decisions for us, but ultimately the consumer pays the cost. And they pay the cost from not getting access to services that would benefit and improve their health, and they pay the cost for paying for the actual direct cost of those services in the market. When will they pay? What I've seen with insurers that I've dealt with, and I've dealt with most of the major employers and insurers in the Minnesota market and many on the national market, that they're viewing pharmacogenomics like another form of technology assessment, or essentially like a drug formulary process, but they'll have a formulary of pharmacogenomics test. They'll have a process for reviewing pharmacogenomics tests, the evidence, deciding whether they will cover it or not, and then establishing a rate at which they will pay for that service. So one of the first things they'll look at is this test FDA approved or referenced in the labeling somewhere. And I'm sure we'll hear in a few minutes from my FDA colleague about the number that are out there, but I think there are at least over 160 drug SNP combinations that are approved or in labeling somewhere in the FDA at present. It may have gone up even from that. Then the insurer will say, is this medically necessary? Does the evidence tell us that this is medically necessary? That's as opposed to, is this test experimental or evidence-based? Now, you might, if you've worked in the pharmaceutical world, and particularly in oncology, remember the battles with formularies over cancer drugs. And there were cancer drugs that were considered medically necessary and those that were considered experimental. Did they pay for the ones considered experimental? Often not. We're going to go through the same battles with pharmacogenomics testing. We're going to have insurers who declare them experimental for a period of time. On the one hand, they're trying to save resources. On the other hand, the insurer doesn't want to pay for your research on a new test until we know that it works. So they're trying to balance their use of resources with what do we know and how do we use them wisely. But we need to work with the insurer community to make those decisions quickly, to identify what does it take to get into and then out of the experimental phase. What troubled me was in a couple of the policies I saw statements like, there's still ongoing studies for this pharmacogenomic test, therefore it's experimental. Well, it may have already proved its effectiveness and we're still learning more about it. That doesn't mean it's experimental necessarily. So there were some fairly cursory summary judgments about what is and isn't experimental. And so we need to inform the insurance community about how to make those decisions more wisely. And then what is the intermediate measure we use? What's the measure we use for a pharmacogenomic test and its effect? Pharmacogenomic tests don't really have a direct outcome. They usually will tell us something about that patient, and then we have to use that information to affect a direct outcome. Rarely does the pharmacogenomic test itself deliver an outcome. So this really is a part of a multi-step process to identify the true impact or value proposition of a pharmacogenomic test. And so what we need in addition to knowing the test and what it tells us about a drug and its use is, how do we implement it in a practical way so that patients' health really does improve with this information? If all we do is the research and we never help those in practice implement it in a way that improves the health of their patients, we really haven't advanced the health of their patients. So we have to make this information very practical. Does pharmacogenomics affect the outcome or endpoint, and what steps in addition to the test are necessary to make sure we get to that endpoint? Is the pharmacogenomic test method itself valid, reliable, sensitive, and all those other things we need to evaluate? Sometimes there are multiple ways for performing a certain test or checking for a certain SNP or allele, and I must tell you I'm not well versed in this science, so I may misstate some things, but if the method is not reliable and valid and sensitive, and there may be multiple ways of measuring certain pharmacogenomic parameters, and we need to make sure that each place that performs it is meeting the right laboratory standards, they've followed the right steps to come up with reliable results. And how do we prove that? And in general, I don't see the FDA approvals addressing that directly. They may indirectly, and we can comment on that later. But we almost need something like a USP standard, like we have for drugs. We have standards for purity and quality of drugs and knowing if they meet that standard. We have CLIA standards for laboratory procedures. We need standards for the pharmacogenomic testing to make sure that those standards are being met. And then what is the value proposition for each pharmacogenomic test? I think we can probably come up with a template or a model for establishing pharmacogenomic value propositions that can be generalized across most drugs, but we'll need to populate it with data unique to each test and each drug and each population. So let me tell you briefly, I looked at a couple of national insurers to see what did they have in terms of pharmacogenomic coverage policies. And I'm going to give you just a couple of examples of the types of statements they make. So first, Aetna had 32 explicit policy statements on pharmacogenetic testing, is what they called it. The first statement was, Aetna considers HLA-B 5701 screening medically necessary for persons infected with HIV-1 before commencing treatment with abacavir or Zylogen. Now this, I'm glad they consider it medically necessary. In case you don't recall, abacavir was discovered here at the University of Minnesota by one of our colleagues, a professor, and it probably had a meaningful place in HIV therapy more than it would have because of understanding the role that pharmacogenomics has in identifying a potential adverse effect and problem with this drug, and I think it had more use because of that. If we hadn't found that, I think people would have been shy to use it because of the fear of serious adverse consequences. A second statement, Aetna considers CYP2D6 genotyping experimental and investigational for predicting responses to beta blockers. Now, I don't know the science, what you believe of that, but what I want to point out here is two key phrases. The first statement says medically necessary. That means they pay for it. The second statement says experimental investigational. That means they don't pay for it. So again, we need to work with insurers like Aetna to understand what moves something from being experimental to being medically necessary. And we need to find ways to get them to move through that process as quickly as possible. Overall, then, of the 32 explicit policies, 13 of Aetna's explicit policies were considered medically necessary. 19 were considered experimental and investigational. We have work to do. We need to continue to inform Aetna. Another national health provider, HealthNet, had also a number of explicit policies. Again, they had 33 explicit statements. The first, I'll give you two statements here. HealthNet considers the following pharmacogenetic tests investigational. Now again, investigational in their lingo means we're not paying for it. Now here they point out sure-gene tests for antipsychotic and antidepressant response, or STAR2R, is considered investigational. Now here, notice they name a proprietary name of a test. Not only the drugs involved, but the sure-gene test. They name a specific test in this case. A second example, they name the GeneSight-Rx or PharmaChip assay genotyping for CYP1A2 and several others to help guide administration of antidepressants and antipsychotics. These also are considered investigational. So in this case, the HealthNet is naming specific tests that are considered experimental, not just the results themselves. And so, again, we need to look at and understand how each of these insurance companies make their decisions. Is this appropriate level? It may well be, but we need to understand what's behind those. In some, they had 9 medically necessary statements and 24 experimental and investigational statements. Insurance coverage and pharmacogenomic testing. So another thing to realize is when we talk about healthcare and coverage, we often forget that there are two sides of a health benefit program, probably more than that, but major pieces are the medical benefit and the pharmacy benefit. And in most plans, they're separate these days. The pharmacy benefit are all the drugs and the formulary and things that are usually dispensed through pharmacies and sometimes involves medication therapy management through pharmacies. And then there's the medical benefit, which is the doctor visits and diagnosis and lab tests and outpatient and inpatient services. And we forget that doctors administer drugs in the physician's office. Do you realize more than 40% of all the amount we spend on drugs today is for drugs administered in doctors' offices? It doesn't go through pharmacies. 40% of all we spend on drugs today are drugs administered in doctors' offices rather than drugs going through the pharmacy. So that becomes important because there are different ways of defining what's covered and what's not. So here I'm going to compare and contrast the medical benefit and the pharmacy benefit. There's explicit coverage of a pharmacogenomic test could be listed under the pharmacy benefit. Explicit pharmacy non-coverage, they could say we don't cover it explicitly. Pharmacy prior authorization could require that a certain genomic test must be done before you can get the drug or use it. We have several policies at the University of Minnesota of that type. We don't say we do or don't cover the genomic test, we do pay for it, but we say you have to have this pharmacogenomic test in order to use the drug safely and before we will approve it. On the medical side, There are very few statements of explicit medical coverage of pharmacogenomic tests. Many of them are covered kind of quietly, but what becomes important on the medical side is you must have either a CPT code or a HCPT codes. These are codes that you use to bill for services in healthcare. And if you don't have a CPT code or a HCPT code, it's much less likely that that pharmacogenomic test will be paid for. There are lists of 25 to 30 CPT and HCPT codes for specific pharmacogenomic tests that have been approved. You can sometimes get pharmacogenomics tests paid for with a generic or non-specific diagnostic test, but a lot of insurers watch those pretty carefully and try to screen out how those are used. But you can sometimes get tests through with simply a generic code. Explicit medical non-coverage of certain pharmacogenomics tests, you're as likely to see explicit statements of what's not covered as you are explicit statements of what is covered. And then medical coverage of non-specified diagnostic tests can also be done. And occasionally, we're advocating trying to get our medical provider to use some medical prior authorizations requiring pharmacogenomic tests for certain drugs before we will pay for those in the doctor's office to be administered. We haven't gotten the medical provider to implement that yet, but we're working on it. CPT codes and HCPT codes, just a couple of examples. The HCPT code, the example I picked out is this one, G9143, which is a test for warfarin responsiveness testing by genetic technique using any method, any number of specimens. So this is covered under the HCPT code on the medical side, and then the CPT code, which comes out of the AMA. CPT codes cover for CYP2C19 with other specifications you see there. So this is an example of the types of codes and how they specify what will or won't be covered. Now, I'll try to wrap this up and remind us there are several challenges. In doing a pharmacoeconomic evaluation, what is this worth? The first challenge we have is often we have small populations of patients who have certain individual variants. And while in general, 85 to 100% of the people in this room have some kind of variation, when we're studying one variation at a time, we have small populations and often requires pretty large samples, and it's difficult to do clinical testing and evaluation. Pharmacogenomic tests do not produce an outcome, as we talked about, and so we need to look at not only what do we expect the outcome to be from the information, but how do we make sure that next step takes place to deliver the outcome. Pharmacogenomics do add value. I think we all in this room probably believe that pretty strongly, but we have to show that pharmacogenomics delivers not only value added, but that it is more than just expense added. Value added isn't an excuse to charge a lot. Value added just means we can show that we can help the system use its resources wisely. The value must be realizable and not just potential. Often we do hypothetical back of the envelope estimates, but we don't ever validate, can we realize the value, the resources, the savings that we talk about. We need to shift from a framework of single pharmacogenomics tests to standardized panels across the system, and I'll talk more about that as I end in a minute. And then we need to advocate for pharmacogenomics testings to insurers and payers. If we have a new drug comes out, the drug company's out there telling the story. Who's telling that story for a pharmacogenomic test to the insurer or to the managed care firm or to the employer? We need to develop processes to educate payers, insurers about the value propositions here. And we need economic evaluation models. And then finally, who's going to fund these studies? Some are being funded. Many of you are doing research in these areas, but we need studies to evaluate individual pharmacogenomic tests and their drugs they have an impact on and the process by which that's implemented in practice to show that it had a value. I think pharmacogenomics, I was around when pharmacokinetics was developing as a science back in the late 60s, early 70s. And it became a science that really enabled our generic boom in the US of making generics available, having bioequivalence testing, creating confidence that we could interchange generics. And I think pharmacogenomics is going to have even more impact on how healthcare is practiced, on how our resources are used. But it raises some really challenging questions in terms of efficacy conclusions. Are there drugs that we have approved, or maybe drugs that were unapproved that would have passed if we understood the pharmacogenomics better 10, 15 years ago. We may well have already made decisions about drugs that were being affected by pharmacogenomics, and we didn't even know what we didn't know. Are there safety issues that we've created black box warnings for or taken drugs off the market, but we could have otherwise kept them on the market if we knew and understood the pharmacogenomics? Are the results of the bioavailability bioequivalence tests that we do to allow generic substitution today called into question for certain drugs that have pharmacogenomic parameters influencing the response to that drug? Maybe some of those drugs aren't as interchangeable as we think if pharmacogenomics weighs in. And I support generic interchange if it's safe and proven, but I think this raises some questions we need to answer. Are the results generalizable across patient populations and groups? Not as much as we used to think they are. We're realizing there are a lot of patient population differences. And then we often use standardized dosing in our labeling, which I think is a good process overall, but if the science starts to tell us that standardized dosing isn't appropriate, we need to identify dosing that's population specific. Just like now the FDA labeling typically has a section for the elderly, a section for children, a section for renal compromised patients, a section for hepatic compromised patients. We may start having a section for genomically compromised patients or specific genomic variants in dosing sections. So what does the future hold? Where does this take us? Issues. As I read the literature on pharmacogenomics and implementation and practice, one of the biggest barriers was that physicians and pharmacists didn't feel like they knew enough to do anything about it. They didn't, so we need to educate better, physicians, pharmacists, and nurses. They felt like they didn't have access to or know where to get the test done or how much it would cost or how long it would take or how to implement it if they got the information. There seems to be opportunity for and maybe some degree of duplication. I get treated at the University of Minnesota and they run a test on me. Then I may go to Mayo for a follow-up or a specialist referral and they run this test again. I may move to California, they'll run the test again. We need to make sure in our system, in our healthcare system, we're not doing something that doesn't change, doing it multiple times over and over and over in the healthcare system. That's a waste of resources. Pharmacogenomics has to be integrated into our electronic medical records and into our health information systems. Some of them have it there, some of them it's just a PDF appendix, but it's not really accessible information in the system. And pharmacogenomics has to be integrated into our payment systems. And it doesn't fit our payment systems well right now, so we need to work on that. Again, we need to develop that value proposition for each drug, test, and use. And we need to make practice more efficient, not more difficult. I think we can learn from some other fields in healthcare. First, I want to point out, you all know what the prescription monitoring programs are? These are the systems that track opioids. The state of Minnesota and virtually every state but one, I think, but Missouri, has a prescription monitoring program where all controlled substances are registered in a statewide database. And any health provider that has a legitimate reason to access that information for patient care can look it up and find out what controlled substance a patient's on, when they got their last prescription, who wrote the prescription. Why can't we do that for genomics information? Aggregate this information in one statewide database. Make it accessible to any provider so it's not a matter of one system versus another creating piles of data, and we each have mountains, but the mountains you can't see from one mountain to the next. Another example would be the Minnesota Immunization Information Connection. Again, if I get an immunization, or if I haven't had an immunization, no matter what provider I go to in Minnesota, they can look it up and identify that I need an immunization, or I've had all of my immunizations. Again, we need a pharmacogenomic system that collects data like this. And the final example in Minnesota is an Allpayer claims database. About 87% of all the patients and all the health transactions in the state of Minnesota from 2009 to the present are aggregated by the state in an Allpayer claims database. Why can't we do that with pharmacogenomic information in the future and use it for practice first and then carefully and respectfully use it for research on the backside? I think the elements of these three systems are quite applicable to pharmacogenomics, and we need to work on advocating a system like this for pharmacogenomics. We need informed consent obtained from the patient. Patient confidentiality can be protected, as it is in these first three examples. Appropriate patient access should be provided, appropriate provider access, and then all pharmacogenomics tests for all patients in the state should be included in the database and made accessible, available. Imagine what we could do to increase practice, to make the information available to providers, to reduce duplication, to get information for payers and make our value proposition statements much more effective. And we need uniform reporting and formatting systems. And then finally, we need to archive the data over time. This is data, some things about pharmacogenomics do drift over time, some don't. Sometimes our methods change, sometimes we find new variations, alterations. We have some choices to make. Should pharmacogenomics use panels rather than individual SNP tests? If so, which panels and when should they be done? Should these be done at birth? Should these be done at puberty? Should these be done at age 18? Should we have panels? When should they be done? Should the panels be standardized across systems and providers? Now, over time they may change, but should we have standardized panels? How do we update the panels and the results from those panels if we create a statewide database and system? How do we minimize duplication of testing and hold down the resources? How do we pay for a pharmacogenomics information system? How do we standardize the pharmacogenomic coverage across systems? As you may know, certain drugs have mandated coverage. Do we want to advocate for mandated pharmacogenomic testing in certain cases? Ultimately then, I think we need more R&D related to pharmacogenomics. Now, hold on a minute. This isn't the R&D you're used to. I think we need more rational care and drug use, and pharmacogenomics can promote that. And we need more delivered outcomes. And if the information is used properly, it will deliver improved outcomes. Increased pharmacogenomic R&D will result in improved health value if we use it properly. I wish you well in doing that. Thank you very much.